Okay, so let's continue with obstructive diseases of the lungs. We have to review COPD, and here you have Numa with the objectives of this lecture. Chronic bronchitis is actually lumped under the umbrella of chronic obstructive pulmonary diseases, or COPD, along with emphysema. These two are different in that chronic bronchitis is defined by clinical features like a productive cough, whereas emphysema is defined by structural changes, specifically enlargement of the air spaces. That being said, they often coexist, probably because they share the same major risk factor, which is smoking. Alright, so bronchitis means inflammation of the bronchial tubes in the lung. And it's said to be chronic when it causes a productive cough, which means that produces mucus for at least 3 months each year for 2 or more years. The main risk factor is smoking, but there are other risk factors for chronic bronchitis that include the exposure to pollutants like sulfur and nitrogen dioxide that they are produced by diesel machines, exposure to dust and silica. These are more people that work in mines, as well as genetic factors like having a family history of chronic bronchitis. So with COPD, the airways become obstructed and the lungs don't empty properly. And that leaves air trapped inside the lungs. For that reason, the maximum amount of air people with COPD can breathe out in a single breath, that's known as the FVC, or forced vital capacity, is lower. This reduction is especially noticeable in the first second of air breathed out in a single breath. We call that FEV1, which is the forced expiratory volume in 1 second. And this is typically reduced even more than FVC. A useful metric, therefore, is the FEV1 to FVC ratio, which since the FEV1 goes down even more than FVC, causes the FEV1 to FVC ratio to go down as well. Alright, so normally imagine your FVC is 5 liters and your FEV1 is 4 liters. All right, so the ratio would be 80%, and that's what is considered normal, at least. All right, now someone with COPD's FVC might be like 4 liters. All right, which is lower than normal, but the volume of air that he or she can expire in the first second is only 2 liters. So not only are both these values lower, but their ratio is lower as well. And this is a hallmark for COPD, which means that less than 80% of this ratio means there is a problem. You got COPD. So all that had to do with air breathed out, right? Conversely, for air going in, the TLC, which is the total lung capacity, which is the maximum volume of air that that can be taken in or inspired into the lungs, is actually often higher because of the air trapping. All right, so chronic bronchitis is a type of COPD that's diagnosed based on clinical symptoms, specifically coughing. If you have strong, productive, and long time coughing due to mucus. But why does this happen? Well, first off, in the lungs, the walls of normal airways have a couple of layers to think about. Lining the lumen of the airway, you've got the epithelium, composed of the ciliated pseudo-stratified columnar epithelial cells. This layer also contains occasional goblet cells, which make some of the mucus that lines the airway. Going deeper past the layer, you've got the basement membrane and loose connective tissue, which is called the lamina propria, which together with the epithelium makes up the mucosa. Beyond the mucosa, there is a smooth muscle followed by more connective tissue, and together these two layers make up the submucosa, and this is where the bronchial mucinous glands live. These are the glands that secrete the majority of the mucus into the lumen of the bronchi, helping to catch and filter out particles, in the air and pathogens. Finally, in the bronchi, but not the bronchioles, there is also a layer of cartilage below the submucosa, which stiffens the bronchus and helps to keep it open. All right, so people who smoke expose their airways to all sorts of irritants and chemicals. Whatever the irritants are, their effect is to stimulate hypertrophy and hyperplasia of the mucinous glands in the main bronchi, as well as the goblet cells in the bronchioles. This increases the mucus production in both locations. Since the bronchioles are smaller and slight increase in mucus can lead to airway obstruction, so this contributes to the majority of the air trapping. To make matters worse, smoking makes the cilia short and less mobile, making it harder to move the mucus up and out of the bronchioles towards the back of the throat to get swallowed. As a result of having too much mucus and poorly functioning cilia, people with chronic bronchitis end up relying on coughing to get rid of their mucus plugs. Okay, so all these mucus in the lungs causes people with chronic bronchitis to wheeze due to narrowing of the pathway available for air to move in and out. These people also have crackles or rales caused by the popping open of the small airways. You can hear that with a phonendoscope or a stethoscope. Also, people with chronic bronchitis often present with hypoxemia, which is low oxygen in the blood, and hypercapnia, which is increased carbon dioxide in the blood. And this is because the mucus plugs in the airway block the airflow, right? And this causes the partial pressure of CO2 to increase in the lungs. Increased PCO2, which is the partial pressure of CO2, means that the partial pressure of oxygen in the lungs goes down. And the lower the PO2 means the partial pressure of oxygen means that less oxygen gets to the blood, and that is what is causing the hypoxemia. This trapped CO2 in the lungs also makes it harder for the CO2 to get out of the bloodstream, which also explains the hypercapnia. The increased CO2 levels in the blood can get so bad that some people develop cyanosis, which is that blue discoloration of the skin. And this is why patients with chronic bronchitis are sometimes referred as blue bloaters. This is compared to the term that we use for people with emphysema. We'll see that later. They are called pink puffers. All right, so in addition to those things, in the areas with decreased gas exchange, blood vessels undergo vasoconstriction in an attempt to shunt blood to an area with better exchange, which if it's a localized problem, then that will work pretty good. But when a large proportion of the lungs are not exchanging oxygen effectively, a large proportion of blood vessels start to clamp down. And this has the effect to increase pulmonary vascular resistance, and to maintain pulmonary blood flow, the body responds by developing pulmonary hypertension. Over time, this increases the work needed by the right side of the heart to pump blood to the lungs, and eventually this right side enlarges, leading to right side heart failure, a process that is known as cor pulmonale. And finally, a consequence of mucus plugging in chronic bronchitis is that people can develop lung infections behind the mucus blockage in the airway. And these infections can worsen the pulmonary and cardiac symptoms. Finally, diagnosis of chronic bronchitis is based on clinical manifestations. Basically, a patient that has productive cough for 3 months, for 2 or more years. All right, so treatment of chronic bronchitis largely involves reducing the risk factors, like, for example, stop smoking, but also managing other associated illnesses. Supplemental oxygen, as well as certain medications like bronchodilators, inhaled steroids, and antibiotics to control secondary infections might also be used. All right, and in the next video, we will start with emphysema.